I'm laughing, you can tell. Inside. Okay. So, taking a look, this all should be review, should be refocusing yourself back on blood gases, stuff that I talked about the first semester, Jeannie talked about last semester, and kind of going back through. Right now, we're just talking about classification of blood gas results. In the fall, we'll talk about really about interpretation, which is a little bit more involved. We'll spend a fair amount of time on that. Looking at oxygenation, looking at ventilation. It's kind of the basis of this. Stuff out of pill beam. There is some stuff in there in chapters 1 and 11. In my lab manual, if you look, there's some stuff that explains this further with some practice problems. And in Egan, chapter 10, it talks about the process of ventilation. Chapter 41 really does a good job. You probably don't have that on your sheet because I just added it in, on respiratory failure itself. So whether it's gas exchange, oxygenation being the problem, or carbon dioxide being the problem, or a combination of both. So, but first, I call this one a butterfly destroyed my roof. Okay. All right, normal values should be very readily recognizing them. In the definitions that are there, I don't think anything is out of there. Rough estimate for PaO2, don't really need to worry about right now. We'll come back to visit this in the fall, but we know that the levels are staged. Okay. The only value that is not, that we haven't talked about yet, and we'll talk about in the fall, is something called base excess or base deficit. It's another value that is reported along with the bicarb, and it tracks the bicarb pretty closely, since one of the primary agents that controls or neutralizes acids is bicarbonate. It is there. We know there's 4 primary disturbances, 2 respiratory and 2 metabolic, or 2 non-respiratory, and that possibility of combined or mixed exists, and of course that would be fair game on an exam. This is out of Egan, this is out of Pilbeam, Cairo. And it's just kind of a way to go through and analyze it. You guys each have your own method of how you classify them. However you do it. Doesn't matter to me how you get to the end point. Remembering, as far as oxygenation is concerned, it's not just the partial pressure of oxygen, it's the combination of what is attached to the hemoglobin and what is dissolved in the plasma. And we can end up having a calculation for an arterial or a venous oxygen content using respective values, mixed venous in the case of venous, and arterial. And then there's that other third one that is there, which is the capillary content. In other words, in the ideal alveolus, if it was a perfect alveolus, every bit of oxygen that was in the alveoli would get across to the capillary. There I go. So that the alveolar PO2 would be what we would multiply by 0.03. And the saturation really is 100%, so we can just ignore that number entirely. We're multiplying it by 1. So we're going to use that value, that capillary content, when we talk about what's going on as far as the percent shunt. Still, I'll come back to this one as one of the most important values, and literally you'll be on rounds in the ICU, and the intensivist will ask the cadre of residents that are standing there, how do you calculate the alveolar PO2? And they'll just got this white look on their face, and they'll ask you, and now he'll go, oh, that's right. because for us, we've kind of burned it into your brain, or hopefully we have at this point in time. Normal value is the problem. It's a 5 to 15 on room air, but a much higher value on 100% oxygen. So you get a little bit of, the problem is as you change FiO2, you change normals, which is one of the reasons that it has a little bit of a problematic situation with it. Okay. There's also these other indices that we can use, the AA ratio, which is normally about 75%, meaning 75% of what's in your alveolus gets across to your arterial system. The PF ratio, which is pretty simple to calculate, especially when you're on an FiO2 of 100%. Whatever the PO2 then is your PF ratio. And the shunt fraction, where normally that's just a small, very small amount of anatomic shunt, and you know what the causes of the anatomic shunt are, right? Yeah. Lie to me. Good. Here's some rule of thumb. You might want to put a real star by this one, and this is one that you'll come back to frequently as time goes on. First of all, if I have a low PaO2, I need to do something to improve it. The knee-jerk reaction is just to increase the FiO2. In the case of a refractory hypoxemia, however, that's not going to work, and we need to look at these other three options that you have there, two of which are just basically looking at doing something to that space under the table. I believe Jeannie talked about that when she talked about improving the mean airway pressure by either increasing the height, adding PEEP so that the legs are longer, or going ahead and lengthening the length of the table, and therefore the space would be greater underneath it by lengthening the inspiratory time. There is also some use of body positioning that can be done. One of the applications we'll use, especially in ARDS, is this concept of prone positioning. I don't know if Jeannie talked about that or not, but placing the patient on their belly and rotating from 12 hours on their belly to 12 hours on their back and forth. And you can imagine a patient in the ICU who has all of these tubes and lines and everything else in, and you're going to suggest to the physician, hey, how about if we prone this person? The nurse loves you very much. They want to be your best friend. They want to kill you because that means I got to flip them on their stomach. And all that, if Foley comes out, the self-extubate, all those things are possibilities. But it has been shown to improve oxygenation in certain patients. So rule number one is rule of thumb one is just to go ahead and try to improve oxygenation by using those techniques. Now, if I'm going up on the FiO2, I go up on the FiO2 until I'm about 60%. After that point in time, it really doesn't help directly to go up on the FiO2 because I know I got a refractory hypoxemia. I need to add PEEP. So go up on FiO2 till I hit 60, then start considering adding PEEP. Got it? Coming down, if let's say I'm on 70% and 12 a PEEP, coming down I want to go ahead and reduce the FiO2 till I'm in a good range, then decrease the PEEP. Okay? So if I got 120 PO2, 70%, 12 a PEEP, drop the FiO2 until I get it below 60, then consider dropping the PEEP. Rule number 4 basically says that anytime I have a situation where I have carbon monoxide poisoning, that's the one time I will always keep it at 100% oxygen. So don't get fooled by a PO2 that's 350 if I tell you that their carboxyhemoglobin level is still 22. You need to go ahead and treat that process. Okay? And we know that a conventional pulse oximeter is not going to be able to be valid. And we need to use a CO oximeter. Hypoxemia is what's in the bloodstream. Hypoxia is a tissue. We know there's 4 different types of tissue hypoxia. Hypoxemic, anemic, circulatory, and histotoxic. And if you remember back, that's the little train scenario that we did back in 1050. Long time ago. That was like lifetimes. Hypoxemia, there's only a handful of causes for that. Either the low alveolar oxygen, secondary at altitude. In our case, it's not going to be the situation. However, alveolar oxygen levels can be reduced also by hypoventilation, which is the most common cause that you end up having. Rarely do we have that third option, but again, we were talking about, those kids with hypoplastic left or right heart. You want to keep them hypoxemic to keep the PDA, to keep the ductus arteriosus patent. And then there's diffusion defects, which we typically identify secondary to exercise. They're good at room air. I'm sorry. They're good at rest. When they start moving is when they desaturate. Okay. And diffusion, we think back to Fick's law, talking about the gas movement across the alveolar capillary membrane and the factors associated with that. Intrapulmonary shunts, remember, are refractory, usually caused by massive atelectasis. And the only way to fix that is to re-expand that FRC, recruit those collapsed alveoli. And usually we do it through the application of PEEP, but obviously there's other mechanisms that we'll find that we use too. And then finally, VQ mismatch, which is probably the most common one in the ICU that you encounter. And it's just basically blood flows going to poorly ventilated areas, and we're ventilating areas that are poorly perfused. Vaguely remember this? 40, 50, 60, 70, 80, 90? If you forgot it, remember it, because it'll come back to you. So in other words, if I tell you that the PO2 is PO2 of 65 and a saturation of 88, that tells me that I have a higher PO2 than I would anticipate. I'm sorry. I have a lower saturation than I would anticipate for that PO2, so I must have a rightward shift. And that's where you got to get back to those things that cause a leftward shift and those things that cause a rightward shift. Go back in time to 1050. Okay. If you can flip to your lab manual, kind of want to go through a few of these. On page 86, there should be a series of blood gases that are there. Unless I got the page wrong? Nope, that's right. So how about that first one? Question is, how would you classify this? And the second question is, am I going to ventilate this patient? Am I going to intubate them and ventilate them? Melanie says no. Steve says yes. Okay, first of all, how do I classify it?
Fully compensated respiratory acidosis.
Okay. Who would you see this with? Yeah, it's a COPD patient. It's your garden variety patient with long-standing COPD, elevated CO2. And would I intubate them? I would not. I would probably do something as far as that oxygenation is concerned. But believe me, there are people who walk around with a PO2 of 32, Gilbert. Is it probably in their best interest? No. Obviously, there's something that we should probably do to treat it, but that, from a ventilatory standpoint, they're perfectly fine. That's the way that they live in the process. How about the second one? Yeah, this is a metabolic problem. Again, that's something I'm going to primarily intubate this patient for and ventilate them, fix what the metabolic problem is. And we'll find out in the fall that there's different, whenever we have a metabolic acidemia, there's a step that we take in there where we look at the anion gap, and that'll help rule in or rule out various disease or metabolic processes that are causing the acidemia. So long as the patient is able to ventilate. Now, this is a weird situation because clinically, I don't think you'll ever see a situation where the CO2 is normal in a metabolic acidemia. Unless we're controlling ventilation through paralysis, that patient's going to hyperventilate. Okay. Does that make sense? Are we still in a fog? Yes, Dana, thank you.
Okay, so I thought like the standard was like if it's below like a 7.5
for a respiratory problem,
For respiratory?
not for metabolic. Unless there's some reason they can't compensate for it. And in this case, I don't think you would ever see a PCO2 of 40 unless we were controlling them already. Just kind of go through these. And what I will do is, rather than taking up time going through each of these individually, maybe what I'll do is I'll print out the answers for these so you have them. Here's an example of a lab error. For right now, I don't think I do any lab errors, but certainly in the fall we do. Why is it a lab error? I have an acidotic pH. I have a bicarb of 77. I don't think that's clinically possible. In other words, although you have a small amount of acidemia causing from the PCO2, a PCO2 of 49 is not significant enough to drop the pH that much. And a bicarb of 77 certainly would push it in the other direction to an alkalemia in the process. Does everybody see my logic there? Okay. We will actually in the fall get to the point where I will give you a blood gas and you will be able to tell based upon that PCO2 how much that pH should have changed. And there's actually math involved. Wow. It's all based upon the Henderson-Hasselbalch equation, so you can go back. Again, this is a typical garden variety COPD patient. And remember, July 2nd's rapidly approaching, and it's when all the new interns and residents come. And they're going to see the PCO2 of 67 and freak out and want to intubate the patient. It's like, put the laryngoscope down, step away from the patient. There's no reason to get involved there. Here's an example of a mixed alkalosis. Both the bicarb elevation and the PCO2 falling will cause an alkalosis. This is an example where that process of going through and evaluating the changes involved. Because basically you have two values that are right on the cusp. Mathematically, it does work out to having a normal pH, but my gut tells me that there's probably multiple things going on here. Something metabolic pushing one way, something respiratory pushing in the opposite direction. Net effect is the pH is normalized, but there's really two primary disorders going on simultaneously. And if you think about patients coming into the ER, they rarely have one problem. They often have multiple coexisting metabolic and respiratory disturbances. In fact, I will tell you it can get so ugly that you can actually have a triple disorder simultaneously. Okay. Here's another example of a lab error. I don't tell you that these are all on room air. At least I don't think I do. Maybe I do. But this is an example of where the combination of the PaO2 and PaCO2 is way higher than the 145 to 150. That's kind of the mathematical maximum you could end up having at sea level on room air. And when in doubt, calculate the AA gradient. If the AA gradient's negative, something's wrong. You can't have more oxygen in your arterial system than you do in your alveolus. It doesn't work that way. Excuse me. How do I know this is probably a COPD patient? Because say that last part again? Your bicarb's elevated. That's how you know it's a patient who's got COPD, because it's a chronic problem. Rarely do you have a metabolic alkalosis that's a chronic problem. I guess somebody who's maybe, what's the disease where you vomit, you self-induce? Bulimia, yeah.
So you said that's a COPD?
My-
patient
I-
or
I-
not? Because it says probably not a COPD patient.
Oh, does it?
Yeah.
That should be probably is a COPD patient. With that level of PO2 and that kind of a bicarb, I would kind of push in that direction. Here's another lab error. I have a normal PaCO2, normal range bicarb, but I have a huge alkalosis. That's not possible mathematically. All right. Let me see if there's anything else here that I really wanted to talk about. Another lab error. And I'll get you these answers so you can have them, okay? The other thing I want to just go back through are some of the ventilator calculations that you've seen previously, probably 1,000 times over. Remembering that the inspiratory and the calculation of a spontaneous tidal volume, we're going to use that 5 to 8 milliliters per kilogram of ideal body weight. We know that there's other things that are involved in that tidal volume. Not every bit of volume that you inspire goes into a gas exchanging area. There's some that have some anatomic dead space. There's also, we haven't talked that much about it, but the calculation of some alveolar dead space, meaning there's some alveoli that on a breath-by-breath basis are inflated but do not have a perfusion to them, okay? And that's what we would just basically call an alveolar dead space. Usually it's negligible, but with patients on COPD, and actually when we start increasing levels of PEEP, we actually start creating some more dead space ventilation, which is wasted ventilation in the process. And then finally, as you saw with those closed suction systems, you end up having some mechanical dead space that is created simply because there's extra stuff in the breathing circuit. Can't really see this that well, but it's on your page. Something called total dead space. Total dead space is the summation of all three of them. Did Mary or Jeannie talk about the Bohr equation and calculating dead space, the arterial minus that mixed expired divided by the arterial, PACO, PICO, PACO? Does that ring a bell at all? No? Okay. Well, if I combine that with my mechanical, I end up with total. The combination of the anatomic and alveolar is known as physiologic dead space. Once I start adding in something that's non-physiologic, like mechanical dead space, I'm going to call that total dead space. And usually physiologic dead space is somewhere on the order of 25 to 40%. So it's not a very significant amount. I mean, I guess it is significant in the sense that it's at least a third of your tidal volume is probably dead space and wasted. I guess as we're not as efficient as we think. But when we start getting higher levels, that's usually an indication for mechanical ventilation. Knowing the alveolar volume, because that's ultimately what we want to be able to identify. Tidal volume less my dead space. And if I take my tidal volume overall times the respiratory rate, I end up with minute ventilation. Subtracting off dead space from that tidal volume, multiplying by the respiratory rate gives me my alveolar minute ventilation. And we know that alveolar minute ventilation has an indirect relationship with the arterial PaCO2. Okay. This is another one of those formulas that you'll want to have a real good handle for. Okay. Because what it's saying is that as I increase alveolar minute ventilation, I decrease my PaCO2. It's also saying that as I increase my carbon dioxide production, I have to increase my alveolar minute ventilation, or if I don't, my PaCO2 is going to rise. So remember how the direct and indirect relationships go. If this goes up, I'm exercising, I'm increasing more PaCO2. If I don't increase this one also, this one's got to increase with it. physiologically, when Melanie goes running, why isn't it that she develops a respiratory acidosis? She's producing more CO2. She's increasing her alveolar miniventilation. There's a physiological response on the part when it senses an elevation in PCO2. Those respiratory centers in your medulla oblongata increase firing to your respiratory muscles to increase your alveolar miniventilation. Make sense? This is why patients with chronic obstructive disease, when they develop a pneumonia, develop a temp, create more CO2, they have to increase their alveolar miniventilation to try and compensate for it, but they can't because they have ventilatory impairments. Their PCO2s rise and they go into respiratory failure. We'll come back and visit this over and over and over again, but that's why patients, this relationship, failure of this is the reason why we end up having respiratory acidemia developing in patients with chronic lung disease.
Is that because you're not blowing it off? You're not.
You can't, right?
Okay.
You're functionally limited because you cannot generate a large enough tidal volume because your muscle is inefficient, or you have area resistance that is elevated, or you, in the case of a ARDS patient, a loss of compliance. Oh, good God in heaven. Don't make me put this shit together. It's hard enough the first time through. We know that there's multiple types of ventilation perfusion relationships. Normally, ventilation perfusion has a value of about 0.8. In other words, alveolar miniventilations of about 4, cardiac outputs of about 5 liters per minute. Comes out to 0.8 as far as the relationship. Dead space ventilation would be something greater than, actually probably greater than 1. Something less than 0.8 is probably a shunt. And then there's a weird relationship of a silent unit where it's getting neither ventilated nor perfused. And if you have a large amount of those alveoli, you're probably dead. What can I say? Dead space, the classic is a pulmonary embolism, but there's other reasons that are there also. Something where perfusion to a functioning alveoli is reduced. Shunts are basically the opposite, where I have perfusion present, but the alveoli is not inflated, and these are basically, again, typically something where there's a ventilatory impairment somewhere along the line. And that's the continuum that you end up having. This is, I think, back in Beachy someplace, this slide from. But there's a continuum from a dead space on through to a shunt, with normal being somewhere in between. And calculation of that shunt, we won't worry about it now. I'll probably throw a question on in the fall. But that's the shunt formula, the classic shunt formula that we learned or talked about or something. But nobody paid attention to me then, as you are not paying attention to me now. I mean, it's just a prolonged process of being able to calculate it. And if you really wanted to, you could, I mean, the steps are there. Calculate your arterial, calculate your venous, calculate your alveolar PO2, because you need that to calculate your, and capillary, plug in the numbers and solve, and voila, you have it. Start getting shunts above 15%, you probably got a patient that's got some significant hypoxemia. And then finally, diffusion defects. We know that under normal conditions, it's not a problem. It's only when you end up having that increase in perfusion, reduction in transit, reduction in time it's spent in front of the alveolus, reduction in transit time, that you end up having the diffusion time being significantly longer, and you end up having a reduction in arterial oxygen. So normal at rest, the patient with the diffusion defect's fine. They get up to walk to the bathroom, they become dyspneic because they're hypoxemic. And we know, based upon fixed law, that it's primarily the thickness of the alveolar capillary membrane and/or loss of surface area that is the problem. In the case of a patient with emphysema, it's a combination of both of them. They lose surface area because they develop blebs and bullae, and they end up having a loss of, or they have an increase in thickness of the alveolar capillary membrane due to some fibrotic changes from the loss of elastin. Vaguely recall this? Okay. Just ran across that one on Facebook. That was pretty good. Okay, let me stop there. And what I will do